Hello everyone, welcome back. Let's start with a question. A 32-year-old man with status asthmaticus presents with severe respiratory distress. Is tachypnic using accessory muscles after treatment with albuterol, ipratropium, and steroid. He becomes suddenly quiet and his wheezing disappears. So that's not a good sign. Arterial blood gas shows that the pH is low, also not a good sign because we know with asthma exacerbation, the pH is usually respiratory alkalosis. So when you start to see normal pH or respiratory acidosis, that means the patient is not compensating anymore and that patient needs to be intubated. So as we can see here, we can see this patient's CO2, PaCO2 is high, and then what's going to be the next best step? So I think this patient needs endotracheal intubation and mechanical ventilation. So I want to say a thank you to one of my subscribers that requested lecture on mechanical ventilation. So we're going to start with Vents 101. And before we talk about mechanical ventilation, let's talk about indications for endotracheal intubation. So what are the indications for endotracheal intubation? So to protect airway, maintain oxygenation, ventilate adequately, and manage work of breathing. And then one thing I must mention is early intubation is safer than waiting for patient for complete decompensation. So it's better to do it earlier than waiting for a complete decompensation because of increased mortality. So let's go through the indications. So one is airway protection failure. So for instance, if patient has loss of airway reflexes like GCS equal less than 8, patient will have stroke with impaired airway protection, severe head injury, or drug overdose. Next is airway obstruction. So if patient have trauma to the face or neck, or patient will have anaphylaxis angioedema with airway swelling and stridor, epiglottitis, or upper airway burn or inhalational injury. So those patients might need airway protection. Next is failure to oxygenate, hypoxemia. So it could be with patients who have very low oxygen saturation despite giving them high flow oxygen, maybe in the setting of severe pneumonia, acute respiratory distress syndrome, or pulmonary edema. Next is failure to ventilate. As we know, ventilation means getting rid of CO2. So ventilation is the term for CO2. And that's why ventilation is inversely proportional to your CO2. So if you increase ventilation, CO2 goes down. So, and if you decrease ventilation, CO2 goes up. So failure to ventilate in the setting of hypercapnia or hypoventilation. So which could happen in the setting of COPD, asthma exacerbation with impending respiratory failure. It could also happen in the setting of neuromuscular disease or drug-induced hypoventilation, drugs like opioid or benzodiazepines. Next is increased work of breathing or impending respiratory failure, like patients with tachypnic or who are using accessory muscle, paradoxical breathing, or patients with fatigue, and you see them, they are really fatigued and diaphoresis. Those patients you might consider intubating them case by case. And then lastly, anticipated clinical cause or procedure related. So like polytrauma patient that require multiple images or surgery, patient with shock with altered mental status, because if somebody have shock, in those patients you might electively intubate them and put them on a mechanical ventilator. And a good thing about that is that will decrease the work of breathing, and that will allow those blood to be shunted to the other vital organs in the body that needs those oxygen supply. And next is status epilepticus and prior to deep sedation procedure. So if patient is going to go needs a deep sedation for procedure or for surgery, then those patients might need to be intubated for those procedure in order to protect their airway. So now let's go to the mechanical ventilation basics. So what are the primary variables? So 5 main primary variables that we need to know. One is the mode of ventilation. And of course, we're going to talk about different modes in the subsequent lecture. 2 is the respiratory rate, which most of the time is represented by F on the ventilator. Next is tidal volume. Next, we have fraction of inspired oxygen, which is the FiO₂. And the last one is PEEP, which is positive end-expiratory pressure. And the first two, the respiratory rate and the tidal volume, those help with ventilation. In other words, they help to get rid of the CO2. And the last two there, the FiO₂ and the PEEP, they help with oxygenation. So those are the guys that help with oxygenation. So now let's start with what help with ventilation. So in other words, ventilation means the removal of CO2. As you remember from physiology, minute ventilation equals respiratory rate multiplied by tidal volume. So that means if I want to optimize my minute ventilation, I could either go up, increase my tidal volume, or I could go up on my respiratory rate. And if you increase minute ventilation, like we mentioned earlier, we said that ventilation is inversely proportional to CO2. So that means if you increase the minute ventilation, that will decrease your CO2. If you decrease minute ventilation, that will increase CO2. So whenever you increase ventilation, that's hyperventilation. If you decrease minute ventilation, that's hypoventilation. So first one is going to be respiratory rate, right? Remember, first component of that minute ventilation equation is the respiratory rate. So respiratory rate is the number of breaths delivered by the ventilator per minute. And in adults, it's usually between 12 and 20. And if patient have ARDS, because in ARDS, your goal is to give them low tidal volume, right? You don't want to put a lot of tidal volume in their lungs because of risk of injury to the lungs. So in those patients, you want to put them on a lower tidal volume. But in order to compensate for that, then you might have to do a higher respiratory rate so that you can maintain your minute ventilation. And for patients who have obstructive lung disease, like patients who have asthma exacerbation or COPD exacerbation, those are problem with exhalation. So because it's a problem with exhalation, then you want to maintain a lower respiratory rate so that will give them more time to exhale. Because if you put them on a higher rate before they finish breathing out all those CO2, the ventilator will deliver another breath for them. Before they finish breathing out, it delivers another breath. And guess what? They're going to be breath stacking. And that could lead to what we call auto PEEP. And that will increase the intrathoracic pressure. And that could lead to hemodynamic instability. So they could become hypotensive. So moving on, so we talk about respiratory. So the next part that helps with ventilation is tidal volume. So tidal volume on the ventilator is the amount of air delivered to the patient with each breath. And it's important to mention that this tidal volume is based on ID body weight, not the actual weight of the patient, is the ID body weight. So how do we calculate ID body weight? So we estimate ID body weight based on height, how tall the patient is. So if it's a male patient, it's going to be 50 plus, so 50 plus 2.3 multiplied by height in inches minus 60, right? And if it's female, instead of using 50, you're going to use 45.5. And it's important to mention that 1 inch equals to 2.54, right? So for normal value, right? So for typically the tidal volume we use in adults is between 6 to 8 mils per kg of the ID body weight. And like we mentioned earlier, if patients have a restricted pathology, like in the case of adult respiratory distress syndrome, you want to put a lower tidal volume. So you're going to be You're going to be aiming for 4 to 6 mils per kg of the ideal body weight. And that's what we call lung protective ventilation, guys. Lung protective ventilation. And let's do one example. So let's say this patient's height is 178 centimeter and it's a male patient. So let's see what the ideal body weight is going to be. So like we said, so for male, we're going to use 50 plus 2.3. So this patient's height is 178. So we're going to convert this to inches. And how do we convert to inches? We divide by 2.54. And then when you divide by 2.54, that gives us, very good, that gives us 70. So 70 minus 60, so that gives us 10. And then 2.3 multiplied by 10, that will be 23. And if you add 23 to 50, then that will give us 73 kg. So that means the ideal body weight for this patient is 73 kg. And if, for instance, let's say this patient have ARDS and you want to put them on 6 mils per kg, then you're going to multiply that 6 multiplied by 73, and that will give us approximately 440 cc of tidal volume. But I love MD-CAR. MD-CAR make life easy, and don't forget, they don't pay me. I'm just mentioning it because it's very useful for me. So I'm not advertising for them, but I find it very helpful. So if you go to MD-CAR and you type in endotracheal tube depth and tidal volume calculator, and you put in the height of the patient in centimeter and you put in the gender, then it's going to give you those values. I love it. It makes life very easy. I don't have to go through those calculations. So if you put the height, right, in centimeter and you put the gender, male, right, so good thing is going to tell you how deep your ET tube should be, right, in front of the teeth, and it's going to give you the tidal volume in the 6 mil per kg of the tidal volume, right, and it's going to give you 8 cc mil per kg of the tidal volume. So that means whatever tidal volume you are setting, it should be between this range. And of course, if patient have ARDS, you might even need to go lower, close to 4 mils per kg of the ideal body weight in those patients, right? And then here you can see, tell us that the ideal body weight is 73, which is similar to what we got in the calculation. So guys, make use of it. You're going to love it. And come back and thank me. So what are the risks with high tidal volume? Remember we mentioned you don't want too much of tidal volume. So what are the risks? It can cause volume trauma from over distension. So it can over distend the alveoli. It can lead to barotrauma, and those patients could develop pneumothorax. They can develop ventilator-induced lung injury, or they could develop what we call biotrauma, whereby because of excess tidal volume, there's release of cytokines. And as we know, cytokines stimulate inflammation, and that could make the lung to get worse. That could make their ARDS to get worse, right? And so based on the common clinical scenario, what are the typical tidal volume? So if you're intubating somebody who have a normal lung mechanism, right? So in those patients, you can aim for 6 to 8 mils per kg of the ideal body weight. If they have ARDS, like we said, we want to do lung protective ventilation. So between 4 to 6 mils per kg of ideal body weight. If they have asthma or COPD, right, like we said, we can do 6 to 8 mils per kg of the ideal body. But most importantly, it's important to set the rate on a lower side to avoid gas trapping. And if they have neuromuscular disease, 6 to 8. If they are pregnant or they are obese, remember that could either pregnancy or obesity could affect the compliance. It could decrease the compliance of the lung. So you may not be able to put a lot of tidal volume in their lungs. So you might need to do on the lower side, like 6 mil per kg of the ideal body weight. And in summary, if you want to improve ventilation, you can either increase your respiratory rate or you can increase your tidal volume. So now let's move on to what help with oxygenation. So what help with oxygenation, like we mentioned, FiO₂ and PEEP. So what's FiO₂? is the fraction of oxygen in the inspired gas. So this represents the percentage of oxygen delivered to the patient by ventilator. And as we are sitting down, not on oxygen, on room air, the oxygen we are breathing in is 21%. That's our FiO₂. And remember, for every 1 liter of oxygen you put the patient on, for every 1 liter of oxygen, that will increase the FiO₂ by what? By 3%. So that means if I put my patient on 3 liter of oxygen, that means their new FiO₂ will be what? So that will be 3 times 3, that's 9. And 9 plus 21 is going to be what? 30. So that will be their new FiO₂ will be what? 30%, guys. But on the ventilator, we can do between 21% to, in other words, what they do on room air, 21% to 100%. So 100% we could represent it by 1. And the FiO₂ is adjusted to ensure adequate oxygenation. And of course, you want to make sure you're avoiding oxygen toxicity. That's why it's important when you put patient on mechanical ventilator, you have to make sure you wean the FiO₂ down to below 60% as safe as possible. Of course, you want to make sure you do it safely, right? So the primary goal of FiO₂ is to keep the oxygen saturation above 90 to 94% and to keep your partial pressure of oxygen between 60 to 80 millimeter mercury. So let's say you're intubating the patient right now, right? So what's going to be your starting starting FiO₂? So in the case of emergency or ICU intubation, right? So it's okay to start with 100%, but like I mentioned earlier, titrate it down rapidly as safe. As safe, it has to be safe. You have to do it safely. And then the safe level is ideally you want it be equal or below 60% of FiO₂. And of course, lower could be better. So don't leave the patient 100% throughout the night. Make sure you wean it down, titrate it down below 60%. So what are the risks of high FiO₂? So prolonged FiO₂ could lead to oxygen toxicity. It can start making free radicals. And what are the free radicals? Like superoxide free radicals. And that could lead to lung injury. It can lead to absorption, athletasis, and it could also worsen what? ARDS. So FiO₂ should be reduced as soon as oxygenation stabilizes. That's the take-home point there. And moving on to the next one that helps with oxygenation, which is the PEEP. So PEEP is positive end-expiratory pressure. And a PEEP is the pressure that the ventilator maintains in the lung at the end of expiration. So remember, if you have the lung, you deliver, the lung expand, right? And during exhalation, the lungs go back down, right? It decreases in size. And that pressure in the lungs that keep the lung open at the end of expiration, that's what we call what? PEEP, right? So that prevents the alveolar collapse, thereby improving what? Oxygenation, because that will help to increase your surface area. And then remember, the more surface area you have, the more oxygenation you're going to have, right? And a normal physiology PEEP from glottic closure is usually around 3 to 5. And on the ventilator, you can do anywhere from 5 to 20 plus, depending on the patient pathology. And there are two types of PEEP that we must recognize. There's what we call extrinsic PEEP, and that's what the ventilator is applying. And there's intrinsic PEEP, which is the one that the patient is generating. And then why is PEEP important? So why do we use PEEP, right? So one, like we mentioned, PEEP helps to prevent alveolar collapse. So it prevents athletasis, right? Thereby preventing athleto-trauma. And keeps the alveolar open and prevent repetitive collapse and reopening injury, which is what we call athleto-trauma, right? It also helps to improve oxygenation, right? It also reduces shunting of blood, so more open alveoli and a better ventilation perfusion mismatch. And the last one, it helps to decrease the FiO₂, because if I can go up on my PEEP, I can help to keep my FiO₂ below 60%, thereby preventing oxygen toxicity. And then what are the typical PEEP setting? So normal PEEP, if you are intubating the patient, normal standard is usually 5, right? If patient has no problem with oxygenation, they have normal lung mechanism, you can start with PEEP of 5. And of course, if they have ARDS, so you might need to consider higher PEEP strategy in those patients, as close to maybe 10. And then for obese patient, though obese patient might also need what? Higher PEEP, right? And a patient with CHF or pulmonary edema, you could also consider higher PEEP for those patients, right? Because as you know, PEEP will increase the intrathoracic pressure, and that will help to decrease the preload, and that will help with the pulmonary edema. And that also, PEEP also decrease afterload. So PEEP decrease both the preload and the afterload, right? And that will also help with what? Forward flow of blood by decreasing the afterload. So what are the risks with higher PEEP, right? So bear in mind, with higher PEEP, it can lead to barotrauma. So patient could develop pneumothorax, they could develop subcutaneous emphysema, whereby you might have to put, if they develop pneumothorax, they might need a chest tube. They could also have pneumomediastinum, could also occur in those patients. And like we mentioned earlier, it could decrease the venous return. So if the PEEP is too high, that could lead to increased intrathoracic pressure, and that could decrease the preload, right? And that could lead to hypotension. Also, over distension of the alveoli, so that could impair ventilation, and that could increase dead space in those patients. And then lastly, it could worsen right heart function, because for instance, if you put somebody on higher PEEP, right, that will increase the right-sided afterload, and that could lead to right ventricular what? Strain. And this could be bad if a patient has a underlying pulmonary hypertension, right? Or if they have massive pulmonary embolism, whereby they already have increased right-sided afterload. And by putting them on higher PEEP, that could make that to be worse, right? So don't forget. And also, if somebody have underlying so let's say a patient has a patent foramen ovale. So if a patient has a patent foramen ovale and you put them on higher PEEP, right? So that could increase the right-sided pressure, and that could cause right to left shunting of blood. So that could actually cause worsening hypoxemia. So it's something to also remember with increasing PEEP. So let's now move on to talk about the initial ventilator setting by clinical scenario in summary. So kind of like a summary of everything we've spoken about in the past. So for a restrictive pathology, right? A restrictive pathology, maybe in the case of acute respiratory distress syndrome or somebody who have interstitial lung disease. Remember, like we said, in those patients, you need a lung protective ventilation. In other words, low tidal volume, right? And in order to maintain the minute ventilation, then you put them on a higher rate. And of course, you can start out with FiO₂ of 100% and a PEEP between 5 to 10. And then you can start winning down your FiO₂ with subsequent assessment of the patient. With obstructive pathology, example like COPD exacerbation, asthma exacerbation. So in those patients, the most important thing, you want to keep your respiratory rate on the lower side, right? To allow time for exhalation, right? So that they don't start breath stacking or to PEEPing, leading to hemodynamic compromise. And of course, your tidal volume could be anywhere from 6 to 8. And then you can start out with FiO₂ of 100% and a PEEP of 5, right? And of course, like we said, with subsequent assessment, we should be assessing the patient and start winning down those FiO₂. And for hypermetabolic states, for patients who have sepsis and DKA, remember, for instance, in patients who have DKA, those patients, they're actually having Kussmaul breathing. They're having deep, right? Deep and rapid breathing. They're taking big tidal volume and they are breathing rapidly, right? Same thing with patients with sepsis, right? they are also having what? Hypermetabolic state. So they are breathing, they are tachypnea and taking a lot of tidal volume. So because of that, you want to mimic that physiology if you put them on mechanical ventilation. So in that patient, you might need to keep them on a higher tidal volume, right? So between 6 to 8. And of course, you want to keep your rates also on the higher side to be able to meet that metabolic demand. And of course, the FiO₂ on the higher side and a PEEP. So FiO₂ 100% and a PEEP of 5. And of course, after intubation, you should be assessing those patients and be winning down the tidal volume. So for instance, let's do a case. If you have a patient with DKA, right? And let's say the pH in that patient is 7.1. And let's say the CO2 is, let's say, 17. And let's say the bicarb is 5, right? So you can see this patient is already trying to compensate for the what? For the severe metabolic acidosis. So let's say you decide to put this patient on a mechanical ventilator because you have to sedate them, you have to paralyze them for the intubation. Guess what is going to happen to the CO2? The CO2 is going to go up, right? Because you're taking away their respiratory drive by intubating them, and that will decrease the pH. And the pH will go below what? 7. And the only thing that the body cares about is the pH. The body cares about the pH. So that's why when you put them on the ventilator, try to mimic what they are doing before intubation. So higher respiratory rate. And the last one there, the last scenario there is the normal lungs. So in normal lungs, right? Keep the tidal volume within the safe limits, and of course, respiratory within normal limits, and the FiO₂ could be between 21% to 100%, depending on how much oxygen they're on before intubation, and the PEEP 5. And of course, you should be assessing those patients and start winning their FiO₂. And guys, we've come to the end of today's lecture. I hope you guys learn something about ventilator 101 today. Of course, before we leave, let's do some questions. So the first question there is: a 19-year-old man brought to the ED after overdosing on opioids is unresponsive with shallow respiratory and with a respiratory rate of 6. Oxygen saturation is low. What is the next step? So this patient is not protecting his airway, and he also has evidence of hypoxemia. And I'm sure with this low respiratory rate, if you do a blood gas, this patient is also going to be what? Hypercapnia. So this patient needs endotracheal intubation, right? Unable to protect his airway, hypercapnia, and hypoxemia. Those are 3 indications in this patient. Next question: a patient with pneumonia and FiO₂ of 100%. Remember, FiO₂ of 1 means 100% FiO₂. PEEP of 5. Oxygen saturation remains at 88%. What's the next step? So we've already maxed out on FiO₂ because this patient is already on 100% FiO₂, but we still have rooms on the PEEP, so we can go up on our PEEP. So I think the best answer there will be increase PEEP, so we can go up on the PEEP. The next question there is a patient has been stabilized on ventilator with oxygen saturation of 98% on FiO₂ of 0.8. So that means that's 80%. What is the next step? Like we said, you have to win the FiO₂ below 60%, right? So the next step would be to reduce what? The FiO₂. You don't want to leave patient on too much of oxygen for long, especially if they've been stabilized because of risk of what? Oxygen toxicity. Next question: a COPD patient is intubated and this is blood gas, so pH is still on the low side and the CO₂ is still on the higher side. Which adjustments helps correct the hypercapnia? As we know that the mean ventilation equals respiratory rate multiplied by tidal volume. So we can either go up on the tidal volume or the respiratory. So let's see what we have in the options. So the best answer there would be what? To increase respiratory rate. The next question here, a patient with severe asthma attack is intubated. What strategy is most appropriate? Remember, like we said, with asthma attack, the rate needs to be on the lower side. So the best answer there will be lower respiratory rates to allow prolonged expiration. Next question, a patient with septic shock is on a PEEP of 8 and then shortly the blood pressure drops. What's the cause of this? So this patient with septic shock, maybe a little bit of maybe the patient is also volume down, and now put them on a lot of PEEP. Remember, we said that PEEP increase intrathoracic pressure, and that will lead to what? That will increase the pulmonary resistance, and that could decrease the venous return, thereby decreasing the preload. So I think the best answer there would be what? Decrease venous return due to high PEEP. And the last question, a patient with moderate ARDS, acute respiratory distress syndrome, requires high oxygen support. According to the ARDS net strategies, which combination is typically used? Remember, in patient with ARDS, you want to do lung protective ventilation. And what does that mean? Low tidal volume, higher PEEP. And the best answer there will be what? E. Thank you guys for watching. Don't forget to like, subscribe, share this video, and I will see you guys in the next lecture. Bye.